Hi, my name is Josh Wortzel, and I'm a first-year medical student at Stanford University, and today I would like to talk to you about something I'm very passionate about, and that's the placebo effect. Specifically, the science behind the placebo effect, how it works from a scientific perspective. And before we begin, I just want to tell you what originally incited my curiosity and interest in this. I was doing my master's in England, and I was sitting in on a lecture about clinical trials. And it so happened that in this one clinical trial we were talking about, they were looking at an analgesic that was used to treat chronic pain. The drug was no better than the placebo. So the company that was running the trial wanted to drop it, and in the process of doing this, they wound up actually engaged in a lawsuit with one of the participants. It turns out that one of the guys had apparently a 10-year history or more of chronic pain, and he had tried everything, nothing had worked, and all of a sudden he'd been on this trial, and like magic, he was feeling better. How could they keep this drug from him? Well, during the course of the court hearings, it came out that actually he was on the placebo drug. And then we moved on to other things in the lecture, but for me, I was just dumbfounded and stuck in this moment, this realization that, God, that means that this guy had been suffering for 10 years, and then just because his body had thought that it should be getting better, it went off. The pain went off. And so, to me, I want to understand how this works. I think that it has the potential to revolutionize medicine and our understanding of this whole psychosomatic mind-body connection. And today I want to share with you the literature, the science that has already begun in this field, and then hopefully inspire you to think more about where it has to go. So with that, let's begin. So just briefly, I encourage you, there's so many interesting phenomenological aspects of the placebo effect that I'm not going to get into. This review by Daniel Keogh and Luke Harrison, forgive me if I'm mispronouncing that, really put together such a great video. I think there's like over 1 million views. And so if you're not one of those million, please watch it, and then maybe you can put me on pause and then come back, because it is great. But today, again, I want to talk about the science, and I want to go talk about what the placebo effect actually is, where we see it, how we measure it, what it's required to have a placebo effect. And then I also want to go into the experimental methods that have been used to test it. I want to look at the molecular biology and our understanding of some of how the placebo effect works that have come out of this. And specifically, I am most interested in this field of psychoneuroimmunology, or the mind's ability to manipulate its own immune system. So I'll give you some examples from there. And then I want to do a summary, a conclusion of everything that we've discussed, and leave you to brainstorm. So we'll go from there to what the placebo effect is. So fundamentally, the placebo is a biologically inactive intervention. It can take the form of placebo pills, sham acupuncture, surgery, but it doesn't have anything biologically active about it that should bring about any clinical effect. The placebo effect, however, is that irony, that in administering something that is not biologically active, you do get some clinical benefit. So this is a schematic of a general clinical trial. We're looking to see if our outcome improves at the beginning of treatment and the end of treatment. Most clinical trials just have these upper two arms. There's the group that's getting the active drug, and then there's the group that's receiving a placebo pill. And most of the time, these two are randomized, so they don't know which arm they're in. But what drug companies hope to see is that this treatment line, the group that's getting the drug, has increased improvement over the group that's getting the placebo treatment. This difference is called the specific treatment effect. The placebo effect, however, is when you compare the effect, the clinical benefit of taking a placebo, and compare that to someone who has not received treatment at all. And that's what this is, the solid line here. Either people who have been kept on a wait list, or were just through some type of analysis assessed as being non-treatment individuals. So that difference is the placebo effect. So where do we see it? As I mentioned, it is perhaps most infamously known in the clinical trial setting, but, and we'll get into some other examples through which it does rear its ugly face too, or I can think beautiful face. But phase 2 trials, that's where we begin to test the efficacy of drugs. And it turns out that 9/10 of these trials fail. Well, why do they fail? Some of the time it has to do with there being nasty side effects or other complications of the medicine you're testing, but sometimes it just has to do with the drug not being any better than the placebo. Now that doesn't mean that the drug's not working, it just means that it doesn't work better than a sugar pill. So interestingly, we're finding that this ratio, this proportion of the phase 2 trials that fail because they are no better than the placebo, is increasing steadily. Over the past decade, or several decades, we're finding that every decade there's a 20% increase in that ratio of the percentage of trials that are no better than placebo. And this is specifically true for conditions that have a psychological component. So depression, anxiety, pain. In fact, 25 to 45% of the clinical trials that test the efficacy of these drugs show that they are no better than the placebo. So this is just a nice little cartoon that's perhaps making the obvious point that, hey look guys, the placebos seem to be getting better, we're doing a better job of making placebos than drugs, and they're certainly a whole heck of a lot cheaper. Why don't we invest in some of these? And I urge you to consider it. The reality is, in America, we're currently spending 17% of our GDP on healthcare, and we're buying it for twice the amount that other people in Europe and elsewhere are getting it for. And the European health is slightly better than our own. So, be that as it may. Our current clinical practice, believe it or not, also incorporates placebo treatment in it, although we don't necessarily recognize it. This was a fascinating study done by Howick et al. In 2013. And basically what he did was he asked over, I think, 1,500 UK GPs, or general practitioners, to fill out a survey. Over 700 responded. And he asked them to list how much they felt or how often they had used a placebo in their clinical practice. And he identified 2 different types of placebos. One is the one we've been talking about, something that is not biologically active. But the other he called an impure placebo. And that is something that has biological activity, but not for the condition you have prescribed it for. So a perfect example of this is someone comes in with what seems to clearly be a viral condition, and you give them an antibiotic for it. That's an impure placebo. So what he found was that for these GPs, 1%, on the weekly basis, 1% had prescribed pure placebos, and up to 77% had prescribed impure placebos. And then when asked to extrapolate their whole careers, it turned out that 12% had prescribed pure placebos and 97% had prescribed impure placebos. So in my mind, there's a lot of controversy around whether or not we should use placebos in clinical practice, when the reality is we do. We already do. And so rather than debate whether this is ethical, I think we should consider, well, how does it work and how can we use it better? But I also want to just take a moment to recognize the placebo effect in our daily lives. It's not just confined to medicine. And these are just a few examples here. Wager and all did a really cool experiment where they had 2 groups of students take a test. One group, they gave the test, done, they graded. The other group, they flashed in front of them for a millisecond or 2 what they said were the answers to the test. Took the flash away, students took the test, they graded it. They compared the 2 groups, and they found that the group that had the answers flashed in front of them did better. But the reality was that actually the stuff they flashed in front of them, that wasn't the answers, that was just gibberish. So it was just this idea that the students felt they would perform better. This is one example of many like this out there. Sports enhancement is another very controversial issue when it comes to the placebo effect. And I particularly like this study. Polo and all took 2 groups of amateur weightlifters. And what they did was they, for one group, they gave them what they called caffeine pills, but actually they were just placebo inert pills. And they measured the weightlifters at their baseline, and then after giving them the pills, saw how their bicep curls improved. And it turns out that because caffeine is a stimulant, they expected to be able to lift more, and they did. However, what I thought was particularly tricky and clever was for the second group, they measured the baseline, and then they gave the participants what they thought were caffeine pills. They were actually placebo. And when they sat down to start doing the weightlifting, they secretly they dialed down the weight so that it was actually less, so that when they went to lift, it was surprisingly light. And yet they thought it was due to perhaps the caffeine. So then when they subsequently retested the second group of people, but this time put the weight back to where it was supposed to be, when they went to lift, they were able to lift more repetitions and with less fatigue than the original group, who had been conditioned to just use this placebo caffeine pill. So again, just this whole idea that the mind imposes a lot of the limitations that it thinks it can't surpass. And then lastly, something we see all over the place is the placebo effect in business. This idea of the Goldilocks price optimization. I don't know if that's a real thing. I just put that together. But basically, you have the same product priced drastically differently. Let's just take a sandwich, 50 cents or $5. Which one do you prefer? Well, the 50-cent sandwich you might think is perhaps low quality. Is it, I don't know, bad grade bacteria-ridden mayonnaise? And the $5 sandwich just seems to be a little hefty for our pocketbooks. So our perceptions of things are very much dependent upon price, and that's why the whole area of marketing exists. But now I want to use a business example to look at how we can begin to measure the placebo effect in a quantitative scientific way. So in this experiment done by Placebo et al., they looked at wine tasting and wine preference based on price. So they had 3 bottles of wine, 20 people, and for the first 2 bottles of wine, they redistributed it into 2 new bottles that they relabeled with new price sets. So for the 1 bottle of wine, and these 3 bottles of wine are all $35 bottles of wine. For all I know, they might actually even be the exact same brand of wine, but I'm not sure about that. And for the first one, they separated into low cost, high cost. The second bottle of wine, they separated into even a greater differential of cost. And the third bottle, they kept at $35, just as a control. Then they asked the participants to taste the wines, and they knew what the prices were, to rank what they thought the overall quality of the wine was. So this is just a qualitative like scale. And these were the results. Basically, you see that for the same wine, these are the same wines, there was a significant difference based on the price. Now, what makes this study, in my mind, different and more interesting than any of these other phenomenological experiments revealing the extraordinary nature of the placebo effect, they did this study in an fMRI machine. And what they found was that a certain part of the brain that lights up for pleasure, it's called the medial orbital frontal cortex, this little area here, lights up more when you feel like you're experiencing something that is more pleasurable. Well, it turns out, just looking at this one middle group here with the greatest differential, if you were to look at how that part of the brain lit up for these participants when they were tasting this wine, they had a much greater increase in the blood flow at this part of the brain when they were drinking the $90 wine. And when they were drinking what they thought was a $10 wine, it was significantly reduced. It was all in their heads, but it was real, it was biological. So that, to me, is really a good segue into looking at how we can begin to delve back into the medical arena of the placebo effect and see how we can use some of these same principles to get at it, again, from a real scientific level. So I'd like to start with this study that was put out by Professor Ted Kapchuk's group at Harvard, the Harvard Studies in Therapeutic Encounter, Placebo Studies in Therapeutic Encounter. And they've done some really great work. I love reading their papers. So I encourage you to look at their other stuff too. But what they were interested in doing is showing that you can see an additive effect of more placebos being administered in a clinical trial. So I'll show you. They took irritable bowel patients and they put them into several groups, but the 2 different placebos they were looking at were as follows. First, the patients could receive an augmented doctor-patient interaction. An augmented doctor-patient interaction would be a doctor who comes in and is very emotive and patient and listening, maybe certainly sits down and maybe touches the patient's hand, takes a moment to think. Dr. Kapchuk called this schmaltzy, but it's just good medicine. A limited doctor-patient interaction is when the patient comes in, or the doctor comes in and says, I'm sorry, I have a busy schedule. If you've got questions, please save them for my nurse. We'll get back to you. does his acupuncture, and goes off. So that leads me to the second treatment. This was an acupuncture study where the treatment was acupuncture for trying to treat irritable bowel. And rather than use a real acupuncture needle, which goes into the subcutaneous area, this was a sham acupuncture study. And basically, it's quite clever. It's like a retractable knife. When the needle is supposed to go in, it goes into the shaft and just barely pricks the skin so that it stays in place. And actually, I talked to Dr. Patrick about it, and he couldn't feel the difference when it was done to him. He's an acupuncturist. So anyway, here were the arms of the trial. There were 262 IBS patients who were randomized into the 3 groups. One group got augmented doctor-patient interaction and placebo acupuncture. The other group just got the placebo acupuncture and what you call limited doctor-patient interaction. And then there was another group that was left on a wait list. Basically, they were asked to not pursue any types of medicinal therapy because it would make it so that they could not participate in the trial. So they knew that whatever the outcomes were for these patients, it was just through spontaneous remission or something like that. Then these patients underwent therapy for 3 weeks. They recorded the patient's baseline levels of symptoms, and then they looked at how these may have changed over the course of treatment, or in this case, no treatment. And what they found was that, indeed, there was an additive effect. The group that had gotten the augmented doctor-patient interaction and the placebo acupuncture had significant adequate relief. That was different from the other groups. And the same was true for quality of life. It had drastically improved. For some of the metrics, and I'm not showing all of them from the paper, we also see that acupuncture, fake acupuncture, seemed to still provide improvement from nothing at all. So it seems as though there's a complicated interaction between different types of placebos having a real impact on, granted, qualitative measures of health. So one thing that is also considered in medicine is this idea that the perception that you are taking a medicine, what it is, may really significantly affect the efficacy of the treatment. So, for example, we've talked about how you can measure the magnitude of a placebo effect by measuring what the placebo is compared to the baseline, no treatment. However, what if, as I said, usually these 2 groups are randomized, the people who are on the trial and the people who are on the placebo, the people who are on the actual drug and the people who are on the placebo don't know what they're on. But what if you were to tell them, the people who are on the drug, you're on the placebo, and the people who are on the placebo, you're on the drug. Would that change this? So that's what this paper tried to do. And, oh no, we're back, technical difficulty. I thought there might have been a technical difficulty, but there actually wasn't, so it was a placebo technical difficulty. But anyway, so going back to where we were, they did just that. They took patients who had migraines, 456 of them, and they told them, because you can't see too well here, this is supposed to be a pill box, that when they had a migraine, they should take a pill from one of these 7 slots. And the pill labels basically were no treatment, placebo, either placebo or Maxalt. Maxalt is a drug used to treat migraines. And that there was repeated. But in reality, one of the placebos was actually a placebo. One of the either words was actually a placebo. One of the Maxalts was actually a placebo, and you can assess the rest for what was actually Maxalt and what was labeled. So the labels were all mixed up. And what they did was they asked the patients to measure their baseline pain and then how that resolved after waiting 2.5 hours. And they were supposed to journal that. And so after looking at this large cohort of migraine patients, they were able to assess roughly what the effect of each of these pills was and how names could change the effect of the placebo. So anyway, or in the drug. What they were able to show is, as you might expect, if you got no treatment, there was really no resolution in 2.5 hours of your pain. For the placebo pill, there was perhaps a slight bit of improvement, but it was not significant. And it didn't really seem to change much for what it was called. For the Maxalt, when it was called Maxalt, or when it was called Maxalt or placebo, it really had a very significant effect. the fascinating element of this study is right here. Here is Maxalt that's labeled as placebo. And you can see that it is dramatically less significant than when the patient is under the impression they're getting Maxalt. So much so that it's actually no more significant in reducing pain than when you have a placebo pill that's labeled Maxalt. So it's this idea that, gosh, okay, so there's obviously a biological mechanism by which this pill is working. Yet at the same time, it has to be compounded and reinforced by a placebo element, because if a patient doesn't believe that they're actually getting a drug, it doesn't work. So that leads me to this next category. What is necessary to have a placebo effect? So one thing that's often promulgated is this idea that in order for placebo to work, you need to deceive someone into thinking they're actually getting a drug. And Dr. Kapchuk's group wanted to test this. So he went back to looking at irritable bowel syndrome, and he took a group of 80 irritable bowel patients and randomized them into two groups. One group, he said, sorry, you're on a wait list, we can't give you any treatment, please stay on it for the next 3 weeks. And record your baseline symptomology and how you feel after 3 weeks. The other group, and again, you can't see this too well, forgive me about that, but he said, I'm going to give you a pill that has no biological activity. It's equivalent to a sugar pill, it's a placebo. However, it's been shown to be clinically active in trying to resolve the symptoms of irritable bowel in clinical trials. So please take it diligently, twice a day for 3 weeks. Recorded them at baseline, recorded them after 3 weeks. And then he compared it. And lo and behold, he was able to show that actually, for most measures, and again, these are qualitative measures, but for most measures, the patients who had knowingly taken the placebo, they had benefited compared to the non-treatment group. Actively knowing that you were taking something that didn't work, still worked. So, the implications for this are broad, but one might consider that perhaps there is just some fundamental element of hope that comes from going to the doctor and then telling you that you're going to get better, even if it's confounded by them saying at the same time that we don't really know why. Another element that is often brought up in the placebo world is this idea of, does someone have to be cognizant of getting a medicine or a placebo in order for it to work or not work? And this really came to light for me when I heard of some vignettes of doctors who would give patients in the clinic an injection of morphine, or they would give them a morphine through an IV bag where the patient wasn't necessarily aware that they were getting the morphine. And what they found was that actually you had to give much more morphine through an IV than you did with just an open injection. And it had nothing to do with the biochemistry and the bioavailability. It had everything to do with whether the patient thought they should be feeling better. So this was a really interesting experiment done by Benedetti and al. Benedetti is one of the leading placebo researchers in analgesia. And he did this interesting experiment where he looked at a group of recently diagnosed Alzheimer's patients and healthy gender and age-matched volunteers. He did brain scans of them, fMRI, and then over the course of 2 days, after drawing blood from them, which is a painful stimulus, he gave them, after that, either an injection of lidocaine, and then asked them to say how long did it take for the pain to go away, or he just said, I'm going to slap some tape on there, how about now? How long does it take to get better? He then waited a whole year, and then he did it again. He took their brain scans, he saw how much the frontal cortex for the Alzheimer's patients, there had been disruption, same thing for the healthy volunteers, and then he did the venous draw, and then either injected with lidocaine or the tape, and then asked for a difference. Now you might expect that, okay, it's lidocaine, you're going to feel better faster, and tape, well, I don't know, that seems pretty inert to me, it shouldn't do anything. Well, in reality, the tape had been impregnated with lidocaine, and the bioavailability of the lidocaine was such that they should have gotten equal doses, it should have had the same effect. Placebo. And indeed, as you and I had just imagined as we were thinking about it, the patients thought they were getting something inert, shouldn't benefit by it, and when they got lidocaine, they thought they should. So if this is a pain scale, and these data are presented in a qualitative, just rough schematic because his results are all in logistic regression outputs, and I didn't want to present that here. But this is the general picture. Basically, the patients, when they thought they were getting lidocaine through injection, and they really were getting lidocaine, when they got it through injection, they thought that their pain really went down significantly, and when they got a piece of tape, it took much longer for them to feel the resolution. And the same is true for the Alzheimer's patients. But what was fascinating is that after a year, and after showing that there was significant frontal cortex degeneration, they were able to show that this differential no longer became significant for patients. In fact, lidocaine through injection worked less well, and the lidocaine through the tape worked better. There was this element that there was no longer the brain's ability, perhaps, to manipulate expectation. So the placebo effect seems to need the central nervous system. So, taking all this, I would like to now move into looking at how we've begun to try to parse this further through experimentation. And we've talked about this some already. You know, we've looked at mostly clinical trials, and this enables you to identify some gross phenomenology of just different things. If you change the placebo labeling, well, then that seems like it changes someone's response to headache medication. We've also been able to quantify, in some type of quantitative manner, the placebo effect by use of a third non-treatment arm. And then we've also been able to start to get glimpses at the biology through fMRI, body fluids, and so forth. Other things I haven't mentioned are observational studies like meta-analysis. And the reality is that there's really a lot of contention and disagreement in the field about whether or not this is helpful at all. As you can see from that original study with the doctor-patient interaction, the different doctors that use in a clinical trial will have dramatic effects on the efficacy of placebo. So it's really hard to compare between and among experiments whether or not a placebo works in a certain circumstance or it doesn't. But finally, what I think the most exciting way of addressing some of these biological components is through use of animal models of the placebo effect. And you might ask, how the heck do you do a placebo study on mice? And my answer to you is classical conditioning. So what is classical conditioning? So some of you may be familiar with Pavlov's dogs, but just in brief, dogs salivate when they see food, small food. They don't normally when they hear a bell tuning. And if yours does, you might want to get it checked out, otherwise maybe it's one of Pavlov's dogs. But if you pair a bell with the food for a certain period of time such that the dog can learn to associate the sound of the bell with the food, he will eventually, or she, will come to salivate when hearing the bell alone. So we can use this same idea of Pavlovian conditioning to look at other aspects of molecular biology with the placebo effect. And specifically, I'm interested in psychoneuroimmunology. So using a conditioning model to enable a mouse to manipulate its immune system. And I'll show you how some of this has been done. But actually, before I do that, I want to just take a moment to just reveal to you that there is more to the field than, of a placebo molecular biology than psychoneuroimmunology. They've been looking at various different things, from the brain to anxiety to depression. Some of these I mentioned, but even Parkinson's disease, cardiovascular system, and the immune system is just one of them. So, the field of psychoneuroimmunology was truly born, more or less, in the 1970s by this man, Dr. Robert Ader, at the University of Rochester. And basically, what he was able to show was that you could condition a mouse to suppress its own immune system through use of the following model. You could train a mouse to drink all its water in a 15-minute period, and then you could give in that 15-minute period something different than its normal drink, saccharine water, something sweet. And then you could give it an injection of a very serious immunosuppressive therapy. We use it in chemotherapy, cyclophosphamide. And the mouse, through that pairing, would come to associate the saccharine water with the immunological suppression of cyclophosphamide. And that is essentially what he showed. And I'm going to go through some of the experimental design that enabled him to show that. So on the bottom left here, you can see what I just described, the conditioning of a mouse to associate saccharin water, which I'm drinking here with Diet Coke, and dissociating the saccharin water with cyclophosphamide. He had other controls, though, to be able to show how this all worked. So the non-conditioned group was given its normal water, but it was given cyclophosphamide. So there was no unique stimulus for which the mouse to associate this injection of cyclophosphamide. It seemed random. And the placebo group just got water and a saline injection. So there was no immunosuppression. So after doing this, he wanted to incite an immune response in the mice. And he did that through use of the poor sheep's red blood cells. And he injected this into the mice. And then he continued to expose them to what we call conditioned stimuli, something that they've been now conditioned to associate to cyclophosphamide, at least some of the mice. So here with the placebo group, we see, and I'll show you there was 2 separate times where he provided them stimuli. With the placebo group, he just continued to give them their water with their saline injection. With the non-conditioned group, he gave them saccharin, but remember, these mice never learned to associate saccharin with cyclophosphamide. So that should, if we were to hypothesize, that really shouldn't have an additional additive effect on their overall immunogenic response. And then he divided his conditioned group into multiple categories. One, the CS0, he just went forth by giving them water and saline like the placebo group. So their immune response should just be based off of this initial cyclophosphamide exposure. And in all reality, shouldn't be different from the non-conditioned group. The second group of the conditioned group, category, CS1, he gave an additional exposure to saccharin. So no more cyclophosphamide, but saccharin, which they had associated with cyclophosphamide. So if the conditioning worked, you would imagine that they should almost think that they got an additional dose of cyclophosphamide and suppress their immune system even more than this group, CS0. CS2, he actually wound up exposing them to 2 more exposures of cyclophosphamide. So for this group, they would have thought, again, if they learned, that they had received 3 injections in total of cyclophosphamide. So just to compare to a group that actually had received cyclophosphamide 3 times, he had the unconditioned stimulus. So we just took some of these guys and gave them another injection, cyclophosphamide twice. And what he showed was fascinating. Basically, and then after that, they sacrificed the mice, and they took the trunk blood and they looked for antibodies in an antibody titer. So what he showed was fascinating. Basically, the placebo group, which never received cyclophosphamide, had the most pronounced immunogenic response, as you might expect. The non-conditioned group, which had been exposed to cyclophosphamide once, had a significantly different immunogenic response. It was reduced compared to placebo. As we predicted, the CS0 group had not a significant difference in immune response to the non-conditioned group because they both had been exposed to cyclophosphamide once, and this group never got saccharin again, so it only thought that it had been exposed to cyclophosphamide once. So we can see that there's no significant difference. It starts to get interesting when we look at these other groups. So CS1, just like CS0, had been exposed to cyclophosphamide and saccharin at the same time. And therefore, when it got saccharin again, it learned, it thought that it was getting cyclophosphamide. So it would thought that it got cyclophosphamide twice. And therefore, you might expect would have a significantly reduced immune response, and it did compared to CS0. CS2 had gotten 2 additional exposures to saccharin, and therefore would have thought it altogether had gotten 3 exposures to cyclophosphamide and had an even more statistically significant different response to the red blood cells. So you see there's a dose response to the placebo. And just to compare it to a group that actually had gotten cyclophosphamide 3 times, we have our unconditioned response. So this was profound. This was the first time someone had shown that you could basically show a dose response to a placebo in immunomodulation conditioning. Now, Dr. Ader, in all his innovation, took this a step further. he said, well, okay, look, if we can suppress the immune system through conditioning, then can't we use it therapeutically? So he took mice that had lupus, and lupus is an autoimmune disease. So by suppressing the immune system, you should stop some of that. So he took mice with lupus, and he conducted a very similar experiment. He conditioned some of them to associate getting cyclophosphamide with saccharin. And he had a non-conditioned group, slightly different this time. They also got saccharin, but they got it several days before they actually got the cyclophosphamide injection. So they didn't learn to associate the two. And his control group had gotten saccharin and just an injection of saline. So this is just to show what he did. Over the next 8 weeks, every week he followed the following protocol. The control group just continued to get saccharin and saline injection. The non-conditioned group got half the time the saccharin long before the cyclophosphamide injection, and then alternating with saccharin and then an immediate injection of saline. So for all intents and purposes, they were just seeing the effects of the 4 administrations of the cyclophosphamide. The conditioned group, however, the C50, got the saccharin directly before getting the cyclophosphamide. So they had made the link that the saccharin was somehow connected to getting cyclophosphamide. So in their mind, they might have learned to think that they were getting actually 8 administrations of cyclophosphamide, which we see controlled for down here, where the C100 actually did get 8 administrations of cyclophosphamide. And so after doing that for 8 weeks, they waited to see what happened. And so each week, they checked for proteinuria, or protein in the urine, which is a sign of kidney failure, which is related to the progression of lupus. And they also looked at the percent of the mice that died. So the percent of mice with proteinuria and the percent of the mice that died. And they graphed it. So this is the proteinuria data. These are the proteinuria data. And basically, it just shows that, so for the placebo group, they didn't receive any immune downregulation, so they were the first to start developing kidney disease. The next group, the non-conditioned group, was significantly longer before they started developing disease, but not as much as the conditioned group. So this is important. These two groups had gotten the same amount of cyclophosphamide, but because this group had been conditioned to think that saccharin was somehow maybe the causative agent for their immunosuppression, they were able to stave off the progression of the disease longer. So you can see here, these two are statistically different. Same amount of drug, statistically different. And then this is the control, where you actually look at the 100% dose that these mice maybe thought they were getting. And they also looked at this with time to death. And basically they showed that in a similar fashion, these mice who were on the placebo control died the first. The mice who were the non-conditioned ones died a little bit sooner on average. And they start to overlap later on, but if you compare the mean survival times, it's significantly different between the group that was not conditioned and conditioned, the C50 group. So this was truly interesting in terms of seeing how perhaps you could use conditioned immunomodulation to provide some type of therapy. So lastly, and unfortunately Dr. Ader recently passed away, but his last study was looking at how you could implement this idea in the clinic. So he looked at psoriasis, which is also affected by the immune system, and did the following procedure. Basically, he took patients who had psoriasis and identified patches on either limb, on certain similar parts of the torso, and the knees, and he, for the first 6 weeks, treated patients with a cream that was an active corticosteroid, Aristocort A. And that was on one of the spots. On the other spot, he gave them moisturizer. And he just wanted to see whether or not there was any type of biological activity for these individuals. Was this working? Because if it wasn't going to work, then it wasn't going to work with what we're about to do. So for the people who did respond positively to the Aristocort A, they went on into the rest of the study. They were randomized into 3 groups. One group, the standard therapy, continued to receive just what they were receiving before. This other group, the partial reinforcement group, received something that was tricky. They were applying the same amount of cream as these guys down here, but actually the active agent within it was 25 to 50% of the standard therapies. They controlled for this with a dose control. This was this cream, but only administered 25 to 50% of the same time, the same rate as the standard therapy. So the idea was, which one is this closer to? If there's no conditioned placebo effect, then maybe these guys are going to really just be closer to this camp. If the patients really were benefiting by the conditioned therapy, they might be closer to the standard therapy group. So what they found was really something what we were hoping for if you believe in the placebo effect, and that's that, in fact, actually, partial reinforcement was much more similar to standard therapy than dose control. And this was done in 2 studies, one at Rochester and then one at Stanford. You can see that the Stanford one was less significant, and this is important. It could be that there's always bias when you're doing something at a home institution where you're invested in the results. But in general, they were able to show that after that initial treatment phase, when they were trying to find people who were responsive to drug, when they randomized them into the trial, so this was the group that got just a quarter to a half of what they should be getting or what they got before, they remained stable or even increased a little bit. The group on the bottom here that continued to get standard therapy and continued to improve, and the group that got the same amount of dosing as this group did basically just as well as the group that was getting around 100% the standard therapy. So this is just another metric, just they were looking at the relapse rate. So for the patients who were getting standard therapy, they had much reduced rates of relapse. For the group that was getting partial reinforcement, they really weren't statistically different from the standard therapy. And then these guys here for the dose control, 1/4 of the standard therapy, really had much more significant relapse. So this is all to say then that, there are many aspects of the placebo effect that we're just beginning to know. One, it's omnipresent. We see it in clinical trials, we see it in medical practice currently, and we also see it in our daily lives. We're beginning to really have a broad range of phenomenological examples of this, the additive effects of the augmented doctor-patient interaction and placebo acupuncture. It appears that the name matters, that depending upon whether someone thinks they're getting a real drug or a placebo, that changes their response to the efficacy of the drug, regardless of what the biological active agent is. No deception seems to be necessary for it, contrary to what you might think, yet you need to be aware that you're getting a drug, and that's whether or not you're under anesthesia and don't know you're getting a beta blocker, or you've got Alzheimer's and unfortunately your frontal cortex is not registering. Conditioning seems to be a really intriguing way of trying to parse this biology of the placebo effect even further in an animal model. Dr. Ader's experiments provide us, I think, a really nice framework through which we can do this, not only in immunomodulation, but other systems. And the psoriasis clinical trial suggests how we might be able to implement some of these findings in clinical practice. But ultimately, there is so much more molecular biology that needs to be parsed about how the placebo effect works. And I encourage you, if you're as excited about this field as I am, to go at it and just continue to explore what to me seems like a new frontier of how biology works, how the world works, and our general understanding of things. So thank you so much for watching, and I hope you enjoyed it, and go at the placebo effect.